Hello, everyone. Welcome to another session of Back to Basics. If you're watching this on Natural Gut Relief, we are glad to have you. If you're watching this on YouTube, please share this with someone, put in some comments, put in some likes, and subscribe to our YouTube channel. My name is Dr. Vivian Asamoah. I'm an integrative gastroenterologist in Katy, Texas, actually West Houston, Texas. And every Thursday, we always have an amazing guest to talk about something related to gut health, because that's truly our focus, gut wellness. And tonight is no exception. I would actually say tonight is extraordinary because we've never had this topic before. And this guest is an amazing speaker, an expert in her field. Welcome, Dr. Rachel Rubin. I am delighted to have you on today.
Oh, I'm so glad to be here. I know we've been trying to pull this off for a while, and it's just an honor to be in your audience.
Thank you so much. Let's just kick it right off. I think people are going to know. I started the post that I was posting, and I was like, we're going to have like a sexologist, urologist, like she's the bomb. So just tell us, Rachel, what do you do?
Yeah, so I'm a urologist. I did a fellowship, like Dr. Vivian did a fellowship in gastroenterology. My fellowship was in something called sexual medicine. And so I do really four things. I deal with issues of libido, arousal, orgasm, and pain. And I take care of all genders, and I deal with these complex issues. And obviously there's a lot of overlapping complex issues. And throughout the lifespan, right, we see so many things come up when it comes to issues of libido, arousal, orgasm, and pain. And so my job is to spend a lot of time with people, to really listen to them, and to really, I always joke, I'm like a sex detective, right? I'm there to really try to figure out.
You're a sex detective. Yeah.
Right? Like I'm there to try to figure out like what's going on with you? What's the biology behind it? What's the psychology behind it? And most importantly, what are your goals and how do we get you to live your best life, whatever that looks like for you? But if I don't know you, I can't come up with sort of that toolbox.
Awesome. So you spend a long time with patients. That's what it sounds like, right? That initial consultation.
Yeah, we spend usually about an hour and a half with people as a first consultation, as a way to really dive deeply into their history of what are their medical problems, surgical issues, what medications do they take, how did they grow up thinking about sex, what do they actually want, what kind of sex do they want to have, what does it look like, who are their partners, what really going deep into sort of things you don't really go deep into with your doctors. And that matters because there is a lot of biology, a lot of hormones, a lot of neurotransmitters, a lot of muscles, a lot of GI issues involved when it comes to sexual health.
Wow, that's amazing. So I just want everyone to listen, because some people on here, I mean, in the natural gut relief world, in our little tribe, I know we have a lot of women ranging between the age of 30 and 65. And I want you guys to really pay attention to this discussion today and share this with friends and family. And some of you may actually realize, you know what, I've never talked to anyone. And we will talk about the correlation between gut health and sexual health, right? But I want you to listen and also be able to connect with Dr. Rachel Rubin, because she is just so generous in the amount of information she shares with her audience all the time, like really like practical information that you should absolutely follow her on Instagram. You should follow her on Facebook. But where is your practice located? How can people find you?
Yeah, so anyone can go to rachelrubinmd.com. I'm on social media at Dr. Rachel Rubin. And we're in the Washington, D.C. area. So just in Maryland, in Bethesda, Maryland, but very close to Washington, D.C. And we have patients come in from all over the place to meet with our team to spend time, because this isn't necessarily something that your doctor in your local town was trained in. And so unfortunately, right, people travel for complex, rare medical diseases or rare cancers, but they don't think to themselves of, oh, I've had pain with sex or a problem with my orgasm for 30 years. I wonder if there's someone who can help me. And so we've really been able to help so many people. I just got a message today from a patient that said, Dr. Rubin, my orgasm is back. It's been 30 years. She's so happy. So it's these wins are super fun.
That's awesome. So you're seeing patients all over the state. Oh,
all
that's
over the country. We
all
have
over the
people
country.
we have
Sorry.
people coming in. We had people coming from Canada this week. We've had people coming
Wow.
in from Germany, from Greece, from it's
Guys,
been a wild ride.
guys, this lady is special. She's phenomenal at what she does. So this is a huge treat. And if you have any issues, definitely, I will post all the information about where you can find her in the comments. But let's get started because I was just talking to my team here at the surgery center, and they were like, gut health, sex health. Dr. V, where are you going now? And I said, there is a connection, right? Because we talk about neurotransmitters being made in the gut, the immune function, 70% of the immune function is made in the gut. Amino acids that are needed to be the precursors for a lot of hormones are made in the gut, fatty acids and all that. So there is a connection. So when I called you and we talked about, hey, let's get on and talk about this together, what immediate connections did you make in your head between gut health and sexual health?
There are so many connections, actually. I don't even know where to start, right? So we see a ton of people with pelvic pain, and there is a giant overlap between pelvic pain and IBS, right?
Mm-hmm.
Or gut health issues. I think there's a lot to do with mast cells and sort of inflammation in general that can really affect both sexual health and gut health.
Mm-hmm.
We see a ton of microbiome issues, so that the increase in urinary tract infections when there are hormone imbalances and hormone deficiencies, and that isn't just in menopause, although it is very common in always in menopause, but it can happen if you're breastfeeding, if you're on birth control pills. There are many things that can alter your hormone status, and that can affect the microbiome of your vagina, of your bladder, and of your gut. And so we see a ton of dysbiosis that happens that really is a gut prop. We see a lot of overlap between gut health and pelvic health.
And so where does it actually start? That's so interesting. Let's just talk about dysbiosis, for example, because this is a common and frequent issue in women who are perimenopausal or postmenopausal, right? And it's a frequent UTI. So obviously something's got awry with the microbiome, generally starting in the gut and everything. I mean, right? The rectosigmoid, sigmoid, bladder, vagina all sit back together in that pelvis, right? So what do you generally see and how do you address it?
So hormones matter for this tissue deeply. And I think hormones deeply matter for the gut, but we don't have, unfortunately, enough gut doctors like Dr. Vivian who actually care about that hormone gut connection. But there are estrogen and testosterone receptors throughout the gut. And so I always say, when you play with hormones, there are consequences. Sometimes they're good and sometimes they're bad. And so but there can always be consequences. So we see a lot of times when the ovaries stop making hormones that you get a depletion of those hormone receptors, and that causes dryness, thinning, inflammation, and especially in the vagina, and probably there are changes in the gut too, but you lose acidic bacteria, like you lose acid. The lactobacilli go away, you lose that acidic environment. And so the more harmful bacteria start to grow, and that predisposes you to urinary tract infections. And that predisposes you to pain with sex, vaginal dryness, decrease and delay in your orgasm, difficulty getting aroused. All of that happens, and just adding a lubricant isn't enough, and it's not going to fix your IBS, and it's not going to fix your pain with sex. But there are treatments that are extremely safe and extremely valuable to use. And so it's really, you're in this very natural, this group that wants to be very natural, that wants to heal themselves with food and yoga and breathing and stretching, and that's all wonderful. However, hormones, which your ovaries used to make, in higher quantities, using local hormones for the local environment, are safe, are natural, are absolutely wonderful, and can prevent things like urinary tract infections. I actually see a lot of patients who have constipation, and it is because their pelvic floor muscles are so tight because of that genitourinary syndrome of menopause. So you treat the hormone problem, and guess what? The constipation problem goes away.
Absolutely.
And so I don't know how we get that into the GI community, but it is their problem to look at hormones.
Yes, absolutely.
Girl, I got to get you prescribing hormones. It's like
I really should. So let's go down to the nitty gritty. Someone's coming in with frequent UTIs. You realize that, you know what, this is because there's hormone depletion. You're talking about local therapies. What would you start with?
Yeah, so there's vaginal estrogen and vaginal DHEA. They're
Mhm.
about equivalent. DHEA sometimes a little harder to get through your insurance company, though not impossible. And so vaginal estrogen, it tends to be more generic, more inexpensive. Even if you don't have insurance, it shouldn't cost you more than $10 a month. There are people listening who were told they needed this therapy and they said, "Oh my God, it costs $400 for my insurance." Not true anymore. It shouldn't cost more than $10 a month. It can be a cream that you put in the vagina twice a week, or a tablet that you put in the vagina twice a week. Some of our patients use rings that stay in for 3 months at a time. So there are different ways to give you. And what it is a very local dose, very tiny dose, almost like putting hydrocortisone on a bug bite, right? Versus taking oral steroids, right? It's very different. So it's a very localized response, but it's enough to acidify the vagina, which brings the healthy bacteria, which actually the data shows it's going to prevent urinary tract infections by more than half. And what's so crazy is women are dying. Women are dying at very high rates of urinary tract infections, urosepsis, antibiotic resistance. You see that all the time. They're getting C. diff. They're getting all these really bad problems. And it's a huge problem because we can prevent more than half of them, but nobody's being offered this therapy because we call it in America just a little vaginal dryness. We just say, oh, it's a little vaginal dryness. It's no big deal. Here's a lubricant. You'll be fine. And it's very serious. We actually just published a paper that said if women in Medicare actually took vaginal estrogen regularly, we could save the government between $6 and $22 billion.
Wow.
Because of what it would prevent with office visits, UTI trips, hospital admissions, and
GI
things like
visits as well. GI visits too. Wow, that is actually amazing. And so this is, I think it's really important you continue to spread this message and the word, because why is it that people in your community, gynecologists, aren't really putting everyone on, topical vaginal creams? Why is it? Where is that disconnect?
So it's a big problem. So we've had this therapy since the 1970s, right? This has been decades and decades. And there's a couple reasons for this answer. I have a couple reasons. It's sort of a recipe for disaster because number one, you get 10 minutes with your gynecologist once a year and your legs are up in stirrups and she's worried about breast cancer, cervical cancer, making sure she gets all her screenings in, and she's got a pregnant lady next door, actually 20 pregnant ladies next door that she has to go see, and she's running behind. So she doesn't really have time to ask you about your vaginal dryness, right? So that's one problem. Problem number two is these medicines have really been about vaginal dryness and pain with sex. And a lot of people don't bring that up to their doctors. And number three, it is only until about 2014, so pretty recently, that we as urologists have stepped in and said, wait a minute, this isn't a little vaginal dryness. This is a severe urologic emergency that we should be treating women with these vaginal hormone products. So the gynecologist never learned that vaginal estrogen would prevent urinary frequency and urgency, would prevent pain, would do those things. So they don't offer it. It's not sort of standard of care. And the worst of all is that these local therapies are extremely safe. However, when you pick up the box, the package says that they cause stroke, blood clots, heart attacks, probable dementia, and can give you breast cancer, when the box is all lies. The box is based on if you took a birth control pill by mouth that had progestin in it. It's not the same. It's like using IV steroids versus a little topical steroid on your hand. There's a difference, right? The difference. So we actually just went to the FDA yesterday to meet with the chief medical officer to say, you've got to take this box labeling off. I don't know that we're going to get there, but this is why there's so much work to do, because you have millions and millions and millions of women who are not being offered a therapy that has existed for decades and actually works and can save money, can save lives. So this is where the advocacy and the social media groundswell comes in, because if we don't, I'm trying to save your grandmother, right? For anyone listening, I am trying to save your grandmother's life, because right now she may be in a nursing home, getting frequent UTIs, leaking all over herself, being miserable from her quality of life, and we can potentially save her life.
That is a huge, huge deal. How many patients do we see all the way from not just the ones in the nursing home? Those are the sort of like it's more severe cases, right? Where they're like, altered mental status, they go to the emergency room and they're like, it's a UTI. And yes, we often see that there's this recurrent, frequent UTI. But even in our younger patients, right, 45, 50 and up, where they're chronically on an antibiotic because they keep getting UTIs.
Which messes up their gut, right?
Messes up their gut completely, right. And then they can't take it. So, I mean, so.
Dr. Vivian, we should do a test. I will teach you how to prescribe this. And your patients that come in with IBS, constipation, and discomfort, I can treat half of them with vaginal hormones and half of them with whatever you usually do, and follow them for 6 months, right? In 6 months, I bet you're going to see an unbelievable improvement in the ones using the vaginal hormones. Their constipation will get better. Their IBS will get better. Now, that's not even saying whole body hormone therapy, which is a whole other topic that can show benefit.
Topical. Yes, yes, absolutely. We should definitely do that experiment and see. So you don't even measure any blood work to start?
No, because it doesn't. There is no increase in blood levels of estrogen with the topical therapy.
Yeah, so you just go straight to topical therapy. I'm really thinking of a population of mine that all have pelvic floor issues, like that hypercontractility, and that probably is the solution.
And they need both. So they need physical therapy and the hormones. So you still have to work with the pelvic floor physical therapist, but without the hormonal, like if you have a sunburn, your muscles are going to be all tight and uncomfortable. Yes. So until the sunburn is healed, you're not going to be able to relax. So the hormone therapy fixes the tissue, but then the muscles then have to learn to relax and to to function a little better.
Absolutely. Absolutely. So tell me, do you ever consistently see some patients with chronic GI issues who also have a lot of, issues in terms of sexual health?
Absolutely. There is an absolute correlation. And I think there are many problems that we see. So we see issues, a lot of gut issues. I believe a lot of IBS.
Yes, because you mentioned that.
I believe a lot of IBS is undiagnosed endometriosis.
Yes. I agree with you 100%.
I have that theory that I believe anybody who has IBS and painful periods should absolutely has endometriosis until proven otherwise. Yes. And the problem is the GI docs are not doing laparoscopy and the urologists are not doing laparoscopy. So you need to then go and see someone and convince them to do a laparoscopy. Because in 2024, we haven't figured out a better way to diagnose endometriosis, which is just absolutely bananas insane. Yeah. But so where you have your GI doctor who's looking at the inside of the GI tract, they're not looking at the outside of the GI tract. And so when you see what endometriosis is scar tissue that can form anywhere inside the pelvis. So you're going to see people with bladder pain, with pelvic pain, with GI symptoms. And so whenever I see patients with a lot of these overlapping conditions, my brain starts to think about things like endometriosis, which some research is pointing to that just being another mast cell disorder. Yes. And that there's some overlap between migraines and endometriosis and vulvar pain syndromes that really, for some reason, your body is sort of just putting these bombs of inflammation.
Immune inflammatory process, right? Right. Yeah, absolutely. Yeah. So IBS is a big one. What about our patients with and endometriosis? And we actually did an entire seminar on how so many of our patients most likely have endometriosis and are getting misdiagnosed.
So bless you. How can we this is so important for the GI community to understand endometriosis and pelvic floor dysfunction. I mean, I can't say loudly enough.
I just think it's more awareness, because when we did that seminar, so many GI doctors reached out and said, I feel the same way. Yes, especially our female GIs, right? When you are in specialties that are also male dominant and dominated, they don't really care, about that. And we're thinking, hey, this could be something else. We need to dig in a little bit further and really get an actual diagnosis. How about your patients with IBD?
So IBD is going to cause a lot of inflammation around your pelvis, right? Because if you have a flare, which is going to irritate your whole pelvic floor. And so no matter, let me see if I've always got toys wherever I go, right? So yes. Your pelvis is just a bowl of muscle, right? So if these muscles have inflammation in them, right, they're going to tighten up and they're going to be really tight. So then that's going to affect your ability to arouse, to relax, to enjoy orgasm, to enjoy sexual health. If you're feeling bloated, if you're feeling flared, if you're having bloody bowel movements, that's not, going to make you all into this, sexual activity that's super fun. And so we see, and then if you're, certainly So we see a lot of overlap between libido issues and pelvic floor issues, when it comes to the IBD patients, for sure.
That makes a lot of sense. So
Every once in a while, you could see Crohn's in the vulva too, which is a very difficult diagnosis to make, but that has been.
Yes. I think I've had in my 10 years about 2 or 3 patients who've had biopsy proven Crohn's in their vulvar area. So very true. Yeah. So we've talked about IBS. We've talked about the link with endometriosis. We've talked about IBD. We've talked about constipation just in itself, right? And the pelvic floor, really the importance there. The other type of patients that I see that I wanted you to talk about in terms of the microbiome shifts are our patients with frequent candida infections. Do you see that? And do you see this topical vaginal therapy probably being helpful there as well?
It's really, really interesting. So I do. So whenever you have patients where they're getting chronic UTIs or chronic yeast infections or chronic BV is another population that's out there, I'm always first to say, what is the foundational hormonal problem with this patient? Is there one? So is the patient on birth control pills, which can really mess up their sort of body's hormone status? Is the patient breastfeeding? Is the patient anorexic or have an eating disorder where they're not having periods? Are they a star athlete where they haven't had periods for a very long time? Do they take a medicine to alter their hormones like spironolactone for their face? There are all these things that can alter testosterone and estrogen levels. Do they have PCOS? Do they have, so I'm looking at are they menopausal or perimenopausal? And by the way, you don't need to have hormonal problems if you can still have hormonal problems if you're still getting periods. So there's a very long period of perimenopause in your 40s that no one's paying attention to. And so when we see the chronic BV and the chronic yeast, I'm a big fan of getting the hormone situation right and then letting the body do its own thing naturally. And I think that, because I really want to limit how many antibiotics and how many yeast medicines these people
that you're giving, especially when it's not working. You're doing the same thing over and over again. So
so you want to make sure you have the diagnosis correct. Now, I have a handful of patients now who are getting these chronic infections or yeast things that they are hormonally, set up to succeed, and we're still dealing with issues. So I can't say it's 100% the answer, but I don't see it as much because we take care of the hormonal issues that are going on. And so that's really, really like an important part of it.
Yeah. So I think for those patients, it's possible that they have like candida overgrowth in their small bowel, and it's just there in a big amount, because we see quite a number of patients with yeast overgrowth.
How do you get rid of it?
Well, so we focus on diet, so sugar reduction significant, but we do treat with antifungals, and sometimes we treat for a prolonged course,
like fluconazole.
So fluconazole, goes through the liver, so it can cause issues. But sometimes most of the time we'll start with nystatin because it's so well absorbed in the small bowel, and then maybe do a burst of fluconazole after. But we can even go back and keep the patient on nystatin for several months, and we see improvement over time. So sometimes if there's yeast overgrowth, then it really makes it difficult in the gut. Then it makes it difficult to, even when the hormone balance is fixed, to probably clear everything out. It's a possibility too, right? Oh, wow. So interesting. Okay. So this is natural gut relief. So do you give any advice in terms of lifestyle, diet,
absolutely,
and sleep? What do you tell your patients?
So all of that is super important. So right,
so part of sexual wellness, right?
So if it's good for your heart, it's good for your genitals, right? Like if you are eating well, if you are sleeping, if you're exercising, there's data to show exercise is as good as Viagra. And if it works in men, I'll tell you it'll work for women. We don't have as much data, but it doesn't matter. We know it works. Self-care, mental health care, taking care of yourself, being safe, being happy, being interested in your own orgasm and your own pleasure. All of that is super important. Good communication is everything when it comes to sexual health. And so absolutely all those things are really important. But I think what we struggle with is, as a society, we love to tell, especially women, of like, you're not trying hard enough. You're not relaxing strongly enough. You're not doing enough yoga. You're not doing enough clean eating. And unfortunately, there's a lot of biology that makes it hard to do those things. And so what I always think about, like a gas tank, So in perimenopause, your gas tank is really empty, and then it gets really full, and then it goes empty, and it kind of keeps menopause is pretty empty. And then if you add an antidepressant, it gets even more empty sometimes. And if you add, aging parents, it might get even more empty. And if you add, kids, young kids like I have,
older kids
older kids, younger kids. So I think of it like a gas tank. And so adding self-care adds some gas back in, adding good communication, adding, an extra, an executive assistant to add some gas in, right? Adding hormones can really increase gas in the tank. And so it's really important that you see that they're tools, and there are many pharmacologic or biologic medication tools that don't necessarily have to be like, ooh, I'm on medicine, that feels wrong. A lot of the hormones that we give are sort of very natural hormones that are FDA approved and are safe and are effective, and actually very safe for way more people than may even believe it. Many of you have been told you can't take hormones for XYZ reasons, and that may not be true. And so there are a lot more people who can and should be offered hormone therapies for their symptoms, whether they are bad sleeping, not sleeping, have osteoporosis, have low libido, or hot flashes. Those are all reasons why hormone therapy may be something to consider.
So, Rachel, who would you not recommend hormone therapy to? Because I think this discussion is definitely something that a lot of my patients are worried about, even when I recommend they see a hormone specialist for HRT. And they're like, well, I heard it can cause cancer, and I heard it can cause this, and I heard, the cardiovascular and this, that. So when you're having the conversation with your patient, who you strongly believe needs to start some form of hormone therapy, what's that discourse like?
It's a great question, and it's really important. My big thing is educating patients to learn about it as much as possible, because it doesn't work if I just hand them 5 prescriptions and say, go take this. It doesn't work. I need people to deeply understand why they're doing something, ask questions, be skeptical, come back at me with what about X, Y, and Z, and what about this? The more I can get my patients and their partners to deeply understand the controversy, the gray, the nuances, because it is not as easy as saying hormones are all good or all bad. They're not even all the same thing, right? Estrogen is different than progesterone, they're different than testosterone. And so the more we can educate people, the more they make really good informed decisions for themselves. And this is where I will tell you, and this is kind of crazy, that the doctors, some of the doctors on Instagram are going to give you better education. The right ones are going to give you better education than your general doctor who did not learn about this in med school. And that is where the frustration lies, because your primary care doctor, your gynecologist, 98% of them never got any training on this. And so they speak as though they know about something they don't actually know about. Right, Dr. Vivian, did you learn about menopause and hormone therapy in med school?
No.
Right? No. I didn't.
No.
And so your doctor has to take extra training, just like I learned how to do it. I learned how to do it safely. I learned the data, and I'm obsessed with it. I am on I am following up. I get Google alerts. I am on it, right? So you want to see someone who deeply cares about this issue, because you deserve, this is half your life.
Yes.
And so this is where we call ourselves the menopause, right? There are people in the menopause space who are trying to be loud on social media so that we can really expand knowledge here. So some people who are good, and there are a couple of new books out that are really helpful. I haven't written a book, but my friends have all written books. There's a book by Sharon Malone, who's Michelle Obama's gynecologist, called Grown Woman Talk, right? So she just spoke. She just spoke at our open house. Literally, Barack Obama tweeted out that everyone should read it. He thought it was a good book. And it's all about sort of what you should be doing as you're in this sort of 40s and 50s, like what are the different, and it's not all about menopause, but it certainly touches on menopause. There's a new book by someone very popular on Instagram named Mary Claire Haver called The New Menopause. And the other people, there are a lot of other people. If you follow me on social media, you'll see me always posting all my friends and all the people kind of in this space. And so the more you can educate yourself and really learn about it, then you can ask really good questions. And when your doctor is scratching their head and just says, no, you can't have this, think twice. Like, can you go see a different doctor? Like you can, you absolutely can try to see a menopause specialist. So so if you go to the menopause.org, you can find a provider there. And then if you want sexual health issues, isswsh.org, that's ISWISH, the International Society for the Study of Women's Sexual Health. It's a long name. They also have find a provider. So you can see someone who has training, not just in menopause, but in the sort of the sexual health around menopause.
Excellent. So that's that combination. Super, super important. Okay. So you want to go to someone who's well-versed, well-educated, and you want to educate yourself, right? That's the first step. And there's so many people out there who can share that information, because there's a lot of information on social media and some of it is not that great. And we are also seeing a lot of, I would say not necessarily physicians, but other allied professionals claiming to be able to treat, or help you with hormone replacement therapy, and doing a lot of cookie cutter stuff, which may not be well suited for each person. So, and some of what I hear you saying, you're like, this we can give to everybody. This makes a lot of sense if you have these symptoms, but I do believe that there's some personalization, of course.
Listen,
and cookie cutter does not work.
This is what keeps me up at night, right? Because women are dying and having worse quality of life. And I believe I have tools that can help them. But because it takes me an hour and a half to get to know someone, and even that's too short for me, I'm always like angry of like, I need 2 hours. I need more time. This is where the math ain't mathin', right? The math is not mathing here. So this is where I have had to expand my practice. And we just trained our first fellow who's going to be joining us. Awesome. I have another doctor who has been with me for over a year who is fully trained. And so this is where, for me, starting a fellowship, I'm starting to get more pre-meds in here who's starting before they go to med school. The more we can spread the gospel and the deep work, because I think this is complex, right? Like I need to have people like Dr. Vivian on speed dial to say, hey, my patient has this, and this. Can you tell me that nystatin dose that you've been using, right? This is really challenging medicine. Mm-hmm. And so you deserve personalized care because you are not like anybody else. And you deserve someone who deeply gives a crap about you, like deeply cares about you and can customize for you, because not everybody needs the same things and not everybody cares about this. Like one patient I see may care about not having dementia, whereas the next patient may care about not having osteoporosis, where the next patient may only care about breast cancer. And then I have people come in here who say, Dr. Rubin, I'm an executive. I need to stay hot. I need to stay smart and hot. Those are the things that I care about, right? And so you have to customize it.
Yeah. And so, this is why, there's doctor and there's doctor. Okay. We're all physicians out here, but you have some physicians like Dr. Rachel Rubin, who's going above and beyond. And the value is just clear. It's as clear as daylight, right? When you compare, the investment that you have to make, that you will have to make in yourself to be able to see somebody, to be able to see a provider like herself who's providing so much value and avoiding the frequent hospitalizations, the frequent unnecessary medications, the frequent unnecessary treatments. That's where you get the personalized care. And I always try and get patients to understand, right? Do you just want to pay a little copay because you have insurance, or do you want to get real care, real medicine by somebody who's doing the research, understands the research, teaching other people? And we're so glad to have you. I mean, we're really so on the, not in natural gut relief, in this planet, because I think what you're doing is just phenomenal and so important. And thank you for sharing the books with us. Thank you for sharing the links. We'll be posting all of that in the show notes and in the comments. We would love to have you on again. And I think I'm going to try and we need to collaborate on some research, because there's definitely a huge gap in everything that's pelvic floor related in gastroenterology today. And that's where we really need to dive in.
I'm very serious in that you could be the niche field for menopausal gut health. Like that is a wide open space where nobody has stepped in. Yes. So we now have the genitourinary syndrome of menopause. Yeah. We have the musculoskeletal syndrome of menopause. So frozen shoulder, all these aches and pains are absolutely hormonally related. And no one has yet coined the term, the gastrointestinal gastrointestinal syndrome of menopause. We could write that
Here
paper,
we
put out
go.
all the data, and you're done. You just
Here
keep
we go.
going.
Here we go. Here we go. Well, I'm in my mid-40s. I'm getting there. I better start really learning this and make sure that I can apply this.
It's going to get personal.
It's going to get very, very personal. Dr. Rachel Rubin, thank you so much for coming on today. This has been a wealth of information. I think people are going to share this with everyone they know. We're going to post wherever we can find you. And I know you do a lot of conferences, lectures, and things. When's your next conference? What are the big ones that you go to?
Yeah, so I do a lot of medical talks where I teach people things. So the Sexual Medicine Society of North America, the International Society for the Study of Women's Sexual Health. I'll be speaking I speak at a lot of urology conferences. So the National Urology Conferences, I'm going to Puerto Rico this year for a big urology conference. So that won't be terrible. But we also do community events. So we have one coming up in the Hamptons with a big community event.
We're trying to plan one in Houston, guys. So
we're going to try to plan one in Houston.
Plan one in Houston. Okay. Oh, that's amazing. You are a busy lady. Tell us something about yourself that is not medicine work related.
Okay, well, this actually, it's kind of a little medicine work related, but as a gastroenterologist is going to like this very much. So everyone can see there that my last name is Rubin. My daughter's name is Billy. So she's Billy Rubin.
Billy. Oh. Did you do that on purpose? Oh, you're such a nerd. Oh my God.
Explain to people why that's funny.
Billy Rubin, breakdown product from the liver, right? Total bilirubin, indirect and direct, one of the liver function markers. And she named her daughter on purpose because she's such an amazing nerd. We love you. We love you, Dr. Rubin. All right, everyone. Well, it was really wonderful having you all with us tonight. Again, my name is Dr. Vivian Asamoah. I'm the CEO of Houston Gastro Institute. I'm an integrative gastroenterologist in Houston, Texas, where we blend the best of both worlds, conventional medicine and integrative and functional medicine. See you guys next Thursday. Bye.